So good afternoon everyone. It's not about the cavity. What I'm going to discuss, some important issues which are usually not discussed in the workshops, is more of non-surgical part, which is, I would not say equally, it is more important than what you are operating. So, like a wrong diagnosis in the wrong patient and a wrong surgical procedure, you cannot expect a good outcome. So once you talk of the outcome, see, endoscopic sinus surgery we all are doing, but many a times we don't get the expected outcomes. And there are many reasons behind it. A lot of work has been done by many people in the literature. And this is just to share certain things. If we take care in our practice, this has really improved my practice. That's what I'm sharing with you. So it can really help improving our practice. So this is what we expect. Patient coming with us a polyp, non-polyposis, whatever kind of a disease, the outcome should be like that. The cavity should look like, if you are operating, that's just the operating part, the cavity should be well healed, the ciliary activity should be good. Ultimately, the mucociliary function we want back. And there should not be any obstruction or anything which impedes the drainage or the ventilation or anything about the cavity. I can skip all this. So, actually what we are aiming at, what we are operating for or treating for is a chronic sinusitis. What I mentioned in the beginning, the wrong diagnosis. Many a time patient coming with the same symptomatology. See, a lot of diseases have the overlapping symptomatology like with the CRS. So we should not go on those symptoms and start treating those patients on the line of sinusitis. We can get a CT scan, get a snapshot. We may find some mucosal changes and looking at the symptom, we start treating on the basis of sinusitis. This is the definition by the European and American guidelines that patient should have at least 2 major symptoms out of these 4 along with the endoscopic confirmation of the disease. There could be polyp, pus, mucosal edema or something in the osteomeatal area or in the sphenoethmoidal recess along with CT confirmation, and that should persist for more than 12 weeks. If it doesn't work, then it is known as something which requires some further treatment. So this is the definition of chronic rhinosinusitis, and we should look at this condition to operate for rather than anything we start operating. And this is, obviously I put this slide, there are 2 distinct varieties which should be looked at differently. They're different from their development point of view as well as the outcome point of view, and the worst is the polypoidal disease because the inflammatory mediators involved are massive in the polypoidal disease. The treatment outcome is altogether different. So just 1 minute I would like to emphasize on what is this disease. See, a lot of people have a misconception that it is an infection. Sinusitis looks like infective disease. It is not infective disease at all. At all. Infection or the bacterial infection can be a disease modifier or a disease activator, but it cannot be the infective disease. This is an inflammatory disease. It's purely an immune complex disease. It has been proven now. What happens? Our nasal mucosa has got its own innate immunity. There's this epithelium, subepithelial, interepithelial junction, then the mucus and ciliary. Any foreign material coming into the nose is trapped in the mucus and expelled down behind in the nasopharynx. It works like that. Wherever this immune function goes down, so it is basically the dysregulation of the host and environmental immune function, which results into influx of a lot of inflammatory mediators, and then the cycle of this sinusitis starts. So what generally happens? Like if your epithelium or anything is attacked by any environmental antigen, pathogen, allergen, whatever, the receptors come into the action, they present the whatever comes to the T cells, B cells, then they start acting, and this is dysregulation, inappropriate response to some antigen that results into all this, that involve the eosinophil, a lot of other material, interleukins, and that's this inflammatory cycle goes on. So lot of, or rather most of the work nowadays is going on to break this what is vicious cycle going on, to attack this so we can prevent this cascade going further. So yes, the first important issue which I wanted to discuss, like we discussed yesterday, why we are getting investigation and what investigation we need for a patient of chronic sinusitis. See, investigations are needed for 3 purposes. One for diagnosis, one for decision making, what you have to do, operating or medical management. And third is to prognosticate. You can prognosticate patient beforehand, before starting and taking up the case for surgery, that this is what your disease quantum and how you are going to behave afterwards. It is very important to tell the patient beforehand. So like generally we get a nasal endoscopy, CT scan done to diagnose, and once we see on CT scan, take up the case for surgery. It's not going to work like this. We'll have to face the worst time afterwards. So what investigation we need? Histopathology I am coming on is very important for prognostication. What you can do pre-op are the eosinophil count is a very good predictor. Any patient coming to me with a eosinophil count of more than 520, sometimes you get a eosinophil count 3000. You can tell your patient your disease is so worse, it requires massive treatment, not only operative, but afterward also you have to be careful all the time to prevent relapse. So you can anticipate the recurrence, which you can start working on beforehand to prevent it. That's what optimizing the outcome. IgE is very, very important for three reasons. Number one, if the IgE is very high, sometimes we get IgE 10,000. If the IgE is so high, there could be three reasons to it we should have in our mind. Number one, like what Ashim said, allergy. If the patient has some specific allergen which is causing the problem, giving allergy, then further sinusitis, we need to treat that allergy. Otherwise, the IgE is not going to come down, and it will go on causing the relapse. One cause. Second cause of raised IgE is staphylococcal infection. It has been proven now the staphylococcus enters attacks the epithelium and goes inside the epithelium and resides in the epithelium for long and keep on causing relapses. So if the serum IgE is very high, the second reason is staphylococcal infection, and we need to be prepared to treat that medically, the staphylococcal infection. This is very, very important.
Nose and the sinus both.
Yeah, in the epithelium, in the mucosa. This is the only bacteria which has the property to reside inside the mucosa, and this is a strategy for the bacteria to evade from the immune response. So that even the antimicrobial doesn't work. And third important role of IgE is to decide whether to go for medical treatment or surgical. It's been very, very clear and proven that if the IgE is low, maybe polypoidal, non-polypoidal sinusitis, IgE is low or normal, your macrolide work like anything, like magic. If the IgE is high, don't think of macrolide therapy. You have to go by you start thinking for the surgical treatment if you get a case of polyposis or whatever sinusitis. Like yesterday we did a case of non-polypoidal sinusitis, plain without polyposis. Ashish's case was non-polyposis. Like we discussing yesterday, when you treat for the non-polypoidal sinusitis, simple sinusitis, his case was a simple sinusitis which led to the orbital cellulitis, had a lot of medical management and now come for the surgery. Had sinusitis been treated earlier, he would not develop the orbital complication. So it's not that the non-polypoidal sinusitis do not come to us. I tell you, 10% of the patients whom we take up for surgery are non-polypoidal, and they mainly present with complications. Most of the patients who present with the facial pain or headache have non-polypoidal. Polypoidal sinusitis is a different presentation. You can segregate. They present with anosmia, nasal obstruction. Those are the prominent symptoms. Non-polypoidal, the facial pain and headache. So we need to know. Then vitamin D, I tell you, this is such an important thing which has revolutionized our treatment. I am coming to this topic with a different slide. It's a very, very important immunoregulator. Whatever treatment you are doing, and if the vitamin D is low, your immune response is not going to work effectively and you need to improve. See, all focus is to improve the immune response. This regulation is at the level of the immune system, at the level of surface mucosa. Then all this cytology and culture, this is important to direct the antibiotics needed. But our important investigation for antibiotic use. See, I told you this sinusitis is not infective disease. You may require antibiotics sometime. How? Simple 10 rupee investigation is the CRP. If CRP is high, then only give antibiotic. That's it. Sinusitis, no role of antibiotics. CRP is raised only in bacterial infection. No other infection will lead to rise in CRP. So if you are thinking of antibiotic, get 10 rupee investigation CRP. If it is very high, or if you are doubtful, you can get serial CRP for 2-3 days, then only use antibiotics. Two important things, I'll come to them later, the immunoglobulin testing. Up to 5% of the patients. See, sometimes what we face, we have done a very good sinus surgery, absolute skeletonization, mucosal preservation, you are giving steroid wash, everything, but the patient's symptoms are not going and disease is relapsing in spite of all good treatment. Up to 5% of the patient have some sort of immunodeficiency, which we overlook. That's why I told you this is a syndrome. We need to look into the basic cause. Imagine if the patient has immunodeficiency and you're treating an immune complex disease, what kind of outcomes you can expect. So, in patients who are getting recurrent purulent infection, not only in the sinuses, sometimes they get lower respiratory infection, sometimes they get ear infection, repeated purulent discharge, think of immune deficiency and get the simple serum immunoglobulins and CD8 counts. That reflects the activity of the T lymphocyte. We want T and B lymphocyte system absolutely intact. So in those situations, we should be just vigilant in case we get such case. Aspirin testing, this is very important. In our series, 12 to 13% of the patients have aspirin sensitivity. This is a different world. This is the worst category of sinusitis. And you can make out from the history, if you go back and recollect, many of the patients have sensitivity to the painkillers. This is the group. You operate 100 times, it is going to come back. After some time, you see the polyps coming back. The steroids not working. These are the cases which ultimately become the steroid resistant, and then your Brahmastra fails, then nothing works. So, what is this aspirin sensitivity? I'll take you into the pathology in a minute. 12 to 13 is a big number, 12 to 13% of patients having NSAID sensitivity, and how it works and what we can simply treat. Now we have around 300 patients of this category whom we desensitize with the aspirin, which is the only answer. Otherwise, so good work you do, after some time the polyps coming back, you are debriding, you are again and again giving oral steroids, and you are not getting into the cause, why this patient is bothering so much, what is going on behind. Simple, you can pick up from the history, otherwise you get the skin prick testing. There are other ways to test also, the nasal challenge or bronchial challenge, but we prefer the history and this skin prick testing from our physician. So what does it do? Aspirin is involved in the arachnoid acid metabolism, and that's very important aspect in our body. So what happens, aspirin is a COX-1 inhibitor. Most of the painkillers are COX-1 inhibitor, not all. So once the patient is aspirin sensitive, he will present 1,000 times the response of aspirin where it works. So what does the COX-1 inhibitor does? See, arachnoid acid is metabolized by the COX-1 into prostaglandins, which are anti-inflammatory. And once it works, the COX-1 works, the prostaglandin forms and keep us healthy. Once the patient is aspirin sensitivity and you block the COX-1, what happens? On the other hand, the leukotrienes form in abundant numbers. And leukotrienes are pro-inflammatory. They do everything they can do, not in the upper as well as lower airway. So these patients present in a triad, we all know it, Samter's triad. The aspirin sensitivity, polyps, and this chronic sinusitis and asthma. So the leukotriene receptors are abundant everywhere in upper as well as lower airways. So what happens? Once the COX-1 is inhibited, the prostaglandins formation is stopped and the leukotrienes are formed in abundant numbers, and they produce inflammation by many means, vasodilatation, smooth muscle contraction, this and this, everything, edema, lot of eosinophil and interleukins influx, everything, and they present with a massive disease. You operate on those patients, and if that system is not blocked, the patient is going to come back because the original disease is going on. So what you need to do this with these patients, operate them as usual, like patient coming to with your polyps. Afterwards, after a month or so, when your healing part is going on, confirm the aspirin sensitivity with the skin prick test, and then subject them to the aspirin desensitization. That you can do at your own setup, or you can have a coordination with the physician if you don't want to take such a headache. That's very simple. It requires 3 days admission. First, once you plan before 7 days, you have to start the anti-leukotrienes. So once you start aspirin, it should not give rise to a major reaction or bronchospasm or something. So prime the patient with the leukotrienes 7 days before. Admit for 3 days. Start first day with a 30 milligram aspirin. The first challenge will start reacting. But the beauty with the aspirin sensitivity is, once you give first challenge, to tolerate that, next 48 hours patient will be free of side effects. So after 3 hours you can raise it to 60 milligram, then again after 90 milligram, next day 150, patient will start tolerating. Third day you will reach 625 milligram, that you have to keep at least for a month, twice a day. Once patient start this much dose tolerating, believe me, all the system will reverse. The prostaglandin will form, leukotriene will stop, and the disease will modify in a different way. You don't need to operate again and again, and then ultimately keep on tapering down, and the final results show you can taper down to 300 milligram a day, but that you have to take lifelong. Like we take aspirin, the cardiac patients take aspirin lifelong. This is something like that. See, a lot of patients who have standard cardiac problem, they are taking aspirin. So a lot of studies done to reduce it to 100 milligram, it starts coming back. So 300 milligram is the final dose. So this is one group we should not ignore. So this is how the investigation panel should cover all the aspects of sinusitis. If you overlook one thing, then you may have a chances of a failure. Histopathology, as I was telling, is important. Very, very important. Every patient of polyp we are operating it, take a biopsy. Non-polypoidal, take a biopsy from the mucosa, from the most representative area. Like in his case, the pus was occupying the entire maxillary sinus, take the biopsy from there. Just small mucosal biopsy from the maxillary sinus. And out of all these, the three things we focus on, this most important, the mucosal eosinophilia. If it is too high, you have to tell your patient, your disease is like that I know that what we have to do, you have to follow this for life, that you have to come for follow-up regularly and irrigation and all these things, otherwise it will relapse. So you tell your patient beforehand to prevent him hostile, that thinking that you have not done a good work. Second thing is the basement membrane thickness. If it is too high, means tell your patient you have to take treatment for long. And third is the biofilms. And coming to that topic of biofilms, talking about the biofilm looks so fancy. What is biofilms and when to treat? If somebody is talking about biofilms, my first question is, how do you diagnose the biofilms? Treatment is afterward. First, you diagnose whether biofilm is there or not, or what kind of biofilm is there. The treatment is secondary. So the only way, the best way is confocal laser microscopy, but your H&E stent can also pick up your cells on the surface have biofilms. So this is important, because once you know the biofilms, your treatment will be geared at a different pace or on the different line. The biofilm needs to be treated, otherwise whatever you treat may go into failure. So vitamin D, as I was telling, and this is our major work we are presently doing at. This is the most important immunoregulator for the epithelial cells, particularly in the nose and the lower airway, and it works by various ways, and the most important being it improves the sensitivity to the corticosteroids. Some patient you give corticosteroids and it doesn't work. You give prednisolone 10 days, not working very well. Believe me, 70% of the patient with polyps have low vitamin D. Low to the extent that the normal should be above 20 and low is below 3. We are getting over 70% in our series have very, very low vitamin D. So if the immune system is affected, how can you expect a good result? So always get a vitamin D and start supplementing to avoid this nuisance. The small problem can ruin your ultimate results. So it's a very, very important thing and very commonly you see. Now, once you are treating CRS, you need to look at the other comorbidities. If you don't look at that, ignore them, the other things will result into the same problem, same symptoms, and ultimately patient will feel that whatever you have done has gone into failure. Like Ashim has already spoken about the allergy. See, the symptomatology is similar. Allergy can directly and indirectly lead to CRS, so much of evidence. 70% of the patients on an average having sinusitis have positive skin prick testing with some allergens. If you don't treat, if you have treated sinusitis, patient will come with the same symptom, rhinorrhea, nasal blockage, sneezing and all this, my nose is still not good, and your whatever you have done has gone into failure. So you need to look at this, and he has already spoken so in detail. Immunotherapy is the only way to, the only treatment which can modify the natural course of disease. Like I yesterday did, is antihistamine, absolutely no role, just you can treat the symptoms induced by the histamine. Ultimately, histamine released from the mast cell and act on the H1 receptors, and you block the H1 receptor to prevent the symptoms of histamine coming into action. So that is the only role of antihistamine to the symptomatic patient. That's it. Asthma. 60 to 70% of the patients of nasal polyp have some sort of associated asthma. On the other side, 40% of the asthmatic patients have CRS. So this is a very, very important link, and my message to you, like we have now developed a good coordination with our respiratory guys. These patients, because of the lack of coordination between the two specialties, are not being treated properly so far. In our country, the status is like that. If you go to the retrospect and think how many times you have had good coordination with the respiratory. This is single airway. If you treat the upper part, you treat the CRS, the asthma symptom improves like anything. If you treat asthmatic patient is sinusitis, polyposis, and if it remains good, the need for the asthma medication is reduced to less than 1/3. The need of steroid rescue is reduced to almost nil, because this is the major factor, and the mediators involved in both the pathologies are same. So if we treat the upper airway, like Ashish said, this is the gateway. If you treat that, your lungs will be fine. So this is important. Age, pediatric is very important. Believe me, in our practice, in spite of all treatments, we get so many pediatric sinusitis, and this is most difficult to treat, I tell you, as compared to the adult one. Because what we're doing, even if you take for surgery, my last choice is surgery in the pediatric sinusitis. I'll think thrice before thinking of taking a pediatric case for surgery. So many reasons. Your surgery success depends upon the irrigation, douching. How can you can't expect such much of, that much of cooperation from the children. Your surgical part is so difficult because narrow spaces, you can't do so extensive septoplasty, this and that. Chances of complication are high, and development of the paranasal sinuses is so variable. So pediatric focus on the maximal medical treatment, but yes, many a times you need to operate. Otherwise, the pediatric, the commonest complication the pediatric patient come for the sinusitis management are present with the orbital complications. So the commonest orbital complications happen in the pediatric, not in the adult patients. So this is important. I'll cover it separately. Smoking, like yesterday, directly, indirectly, it disturbs the mucociliary activity, and if the patient continues the smoking, you can't expect a good mucociliary clearance. There are so many factors it directly affects. The smoking, see, this is why I am enumerating, so you can start telling your patients that you need to quit smoking if you want good results. And if you are posting that case, ask him to quit smoking and come after a month for surgery. This is very, very important. You'll have excellent results, because ultimately the outcome is your credibility. Otherwise, you'll not have a good outcome. Immunocompromise, I already mentioned, you need to treat. Anatomical variants are the simplest situation that you can tell your patient, get surgery done and you'll be all right. Like so many anatomical variants, concha bullosa, paradoxical terminal causing recurrent sinusitis, osteometal block. These are favorable patients. These are the patients for limited surgery. Like if a solitary sinus is affected, you can treat that sinus. You don't have to go for a full house. So this is a important thing. You can tell your patient you have a favorable chance of result. Revisions, we all know, is a challenge. Biofilms. Now I come to this topic. This is very, very important. I'll cover in a different side. Osteitis. What is osteitis? See, what is this chronic sinusitis? A chronic inflammation of the lining mucosa of the paranasal sinuses for months and years. The lining mucosa is inflamed, the underlying bone can also get inflamed. So if the underlying bone, the disease is so severe to have involved the underlying bone, that becomes the nidus of the repeated problems. So if you observe osteitis anywhere, when you are tackling surgery, remove the osteitic bone, and keep in mind these are the most resistant patient. In the post-operative period, you have to irrigate for longer period, otherwise there will be chances of relapse. So these are the things which makes you alert that you have to be vigilant about this situation. So pediatric is challenging, and our treatment is, I told you, for pediatric patient, the first surgical treatment, once it comes to surgery after failing the medical treatment, is adenoidectomy. Adenoid harbors biofilms, and you need to address that. Otherwise, 80% of the time you can avoid sinus surgery if you do a proper adenoidectomy and remove the biofilms. But like Kirtner sir asked yesterday, when would you operate? Definitely in a pediatric patient. This is the condition. Now we have so far 12 patients. Still, none of them is doing very well. After we have done everything, after explaining everything, because the problem is genetic. Your chloride transport channel is not working, so that it is absorbing the water from the surface and the secretions are viscid. So viscid secretion, you have to deal with them on a gravitational basis. So nasalization is the answer. Middle turbinate to, septum to lateral wall of the maxillary sinus. Remove the middle turbinate A1. All sinuses wide open, do the endoscopic medial maxillectomy, go up to the lateral wall. So nasalization, the entire cavity is open for gravitational drainage on both sides, and you need to tell them long-term, lifetime irrigation with the antibiotics and the steroids. That's the only answer so far. Lot of people gave lot of therapies are going on like surfactants and this thing, mucolytics, but nothing is working practically. The gene therapy is now coming up in a big way, but I am not aware of that, what we can do for so. So the pediatric, the main treatment is medical. Same medical treatment for pediatric like adults. You need to advise them strongly the nasal sprays, mometazone, or we prefer mometazone, and there's a least systemic bioavailability, less than 1%, and the saline irrigation. That's the only answer. You can give more vigorously, unlike adults, the more pulses of oral steroids and antibiotic in pediatric patient, because you want to avoid surgery anyhow. So pediatric work like that, but if nothing works, then, and if it comes to surgery, then adenoidectomy is the only answer. Surgery, sinus surgery, the last answer to me, and that you have to counsel so much to the patient that once they are prepared, don't only you think of taking that. I'll skip that video of the adenoidectomy you have seen. So biofilms, this is one thing, how to diagnose, like I told you, the histopathology by H&E stain, and once it comes positive, then what you have to do? Mostly 90% of the biofilms in the nose are because of Staph aureus. So now lots of treatments have been proposed in the literature about the biofilms. How does it work practically? Like a lot of people talk about the mupirocin solution for the biofilms. Yes, it is mentioned in the literature, the mupirocin powder irrigation. How is it feasible in India? I have tried for last 1 year several times to acquire the mupirocin powder. It's not available in India. It's banned in India. There are certain drugs which are not approved. Mupirocin is available as a ointment, tea bag, like many other brands are available as an ointment, which you can't mix in the gel form and in the gel preparation and irrigation. So if we are talking of mupirocin irrigation, it's not practical in India. The only practical thing which works, which we have done many a times, and I tell you, this is the thing which works. You can tell your patient, order at the Amazon, buy it 813 rupees. This spray lasts for 1 month and don't give any antibiotic. See, the problem with the biofilms, what are biofilms actually? There's an aggregation of the bacteria on the surface mucosa, and this strategy they develop to evade the host immune response as well as the antibiotic therapy. If the antibiotics have to work really on the biofilms to treat them, the concentration of the antibiotic needed is more than 1,000 times. That is not practical. So topical antibiotic is a high concentration can work. That's why this strategy of mupirocin and other antibiotics come. Like we sometimes give suspecting Pseudomonas or tobramycin. This we do sometimes in the post-operative period. Most commonly when we see the purulent discharge, it looks like Pseudomonas on the culture sensitivity. Tobramycin, 5 ampules of tobramycin, 2 ml ampules of 80 milligram of tobramycin in 1 liter of saline and irrigate twice a day. It works very well. A lot of people do gentamicin, but we prefer tobramycin, and it works. But the best thing it works, colloidal spur. Johnson baby shampoo we have tried, but it's not practical. It gives irritation and it's difficult. 5 minutes. Sodium hypochlorite again. Then all these things create irritations, and it's not practical to do. It looks good, impressive. Manuka honey. Don't get confused. Not honey which secreted by honeybee. It's a pharmaceutical product. So don't go back and apply honey in the nose, otherwise that will attract the ants. Manuka honey is a pharmaceutical product, is a drug known as methyl glycol, and it is banned in India, number 1. It is produced by only 2 companies from the New Zealand, that is Watson and Sons and Hills Laboratories. It is otherwise not produced anywhere in the world by any other company. So this is the true Manuka honey, which has an antibacterial property, and it has to be used Why these two companies have been recognized? They have produced this in the filtered form at the concentration of 1.8 milligram per ml, which is applicable or which is advisable for the nose, approved for the nose. Otherwise, whatever concentration anything used can be harmful. Xylitol is coming up, I have never used. Now, the macrolides, as I was telling, they have a property of intracellular accumulation. This is the only antibiotic which accumulates intracellularly. So macrolides are versatile and macrolides can work even in the biofilms. So in the adults, the same maximal medical therapy. Steroid is the mainstay. It works at all levels of the chronic sinusitis cycle. You can give in between pulse doses of steroid, but you can't give for long. So in the Western literature, in the American literature, you know, the commonest indication of sinus surgery. Proven case of sinusitis, maybe whatever extent of disease in the paranasal sinus CT scan. If the patient requires repeated doses of steroids more than twice in 3 months to control his sinusitis symptoms, irrespective of the disease, the straightaway indication for sinus surgery, so that that patient can be subjected to a topical irrigation therapy and the topical steroid therapy. And this is the mometadone. Macrolides, like I told you, they have a property like anything. They are not used as antibiotics, just immunomodulators, and they work at various levels to modulate the immune system in the sinusitis. So I'll just quickly, this is very, very important slide. So besides the medical treatment for the sinusitis, what we have discussed, the saline irrigation and the steroids, what other treatment can work? I'll just do pictures in the post-operative irrigation. So like these are the things one can use, and everybody is free to use anything you want to. You can impress your pharma guys, you can oblige them by using, but practically in the literature, I tell you, you go back to the literature, review the strategies, review the guidelines by the top authorities. Number 1, antifungal, 0 role, unless the fungus is invasive. Mucolytics, no role. Decongestant, no role. If you are treating chronic sinusitis, nothing else. Antihistamine, no role. Bacterial lysates, yes. Bacterial lysates is available in India and produced by only one company, the Lupin. Bacterial lysates is what? Probiotic and bacterial lysates modulates the intestinal bacterial flora, and that they work to modulate the immune response. It is available by the Lupin in the name of Ismigen. You have to give 10-day course for 3 months, and that is effective. That works. It is proven in the literature. Anti-leukotriene, montelukast, no work, except the patient has asthma or something like that. Aspirin sensitization, yes. Immunotherapy for allergy. Monoclonal antibodies, not approved in India for use, but now it has been approved in the US. This omalizumab is a monoclonal antibody to serum IgE. IgE is the main pivotal role in the CRS. If you block the IgE, the entire cascade will stop. So they give intramuscular injection on a monthly basis for 6 months, and everything comes under control. So this is the future of this disease. When if it comes into action, approval, you can block the entire cascade of this medical disease, so the patient may not require a surgery. And colloidal silver, as I mentioned. I will escape this. So topical therapy, lastly. We are discussing for last 2 days about topical irrigation. So what kind of topical irrigation, how can we use? So these are the things on which the topical irrigation matters. The delivery technique, device, the volume, pressure, all these things we discuss here. That what kind of a cavity? You do a mini fest and you are expecting your topical to work everywhere. How can it work? You need to have a good access to all the sinuses. So anatomy is important. See, this is the common position which people are doing. Don't take a picture. I never recommend this. This is not to be done. This will never allow the solution to reach anywhere. This is the position which we recommend. Namaz position. Ask the patient to bend forward and lean by 60 degrees. And then if you irrigate like this, it will reach everywhere, olfactory cleft, the sphenoid sinus, everywhere. And this has been proven by the radionuclide studies. The irrigation solution is stained with the radionuclide material and it reaches everywhere. So this is the position of some patient. If they can't do this, some elderly patient probably sometimes they are not able to do it, you can advise this lying head back position. And this is similarly avoids allows the solution to reach everywhere. So this is important, something I wanted to share with you, and we can go ahead with the surgical.
I think on behalf of the all ENTs, I think I should touch your feet. You are the ultimate genius. Milligrams, micrograms, chala surgery bhi karta hai. I really am overwhelmed. You are just incredible. Okay, folks, we need to go down. He's really a genius. I mean, I cannot. I'm so fortunate to have him for everything. Okay, let's move down and we will continue our. Yeah. Sorry, apologize to the auditorium people. We have overshot a little bit. Yeah. No, we had to vacate the auditorium. Yeah.